Thank you. And thank you so much for the opportunity to chat with you today on this, very important educational talk. I've gotten a lot out of it just listening along, and I hope those I can share a few minutes about the wonderful nonprofit that I work for. I'm going to share my screen. Now it looks like I need to be able to share my screen. It says it's disabled. I'm not sure why.
Let me try to give you allow. Oh, there you go.
There we go.
Awesome.
Thanks again. So as I said, I work for an organization called Hadley. And we are a nonprofit located in just north of Chicago. And I'd like to think of Hadley as a 100-year-old startup. We are dedicated to helping those with visual impairments, and we've been doing so for 100 years. However, let me explain a little bit about the combination of 100 years old and yet still a startup. It all started with this gentleman I'm showing on the screen now. His name is William Hadley. And it was 100 years ago, just 100 years ago last year. He was a school teacher in Chicago. He lost his sight as a complication from the flu pandemic of 100 years ago. And one of the things that most challenged him was the printed pages of his extensive library no longer being useful to him. He fell into a depression for a while there, and then decided that he could find another way to continue to read and enjoy life again. And he basically taught himself Braille, and therefore then was able to do one of the things he most enjoyed in life. And when he mastered that for himself, he decided to combine his skill at teaching with his newfound skill at Braille, and reached out to other adults with vision loss, knowing that others were likely in the same boat as he had been prior to learning Braille. And so he started teaching again. And his first student was a woman in Kansas who, like him, had lost her sight later in life. And Hadley sent her lessons in the mail. It was kind of a correspondence way of learning Braille. And the Hadley organization was born. As I said, that was the year 1920. At the time, this correspondence way of teaching Braille was revolutionary. And as you can see, I'm showing a print ad from way back in the day. And it shows William Hadley, as well as a couple of his students, and a mailman getting mail from the building here. The headline is Hadley's doing the impossible, but Hadley did do it, and quite successfully. And we've taught Braille to more folks worldwide than anywhere else. And in fact, back in the day, we were known as Braille by mail. Fast forward 100 years, and you can see a modern foyer of Hadley today. This is Hadley. In July 2020, our centennial year, we relaunched Hadley with a strong focus on using today's technology to reach and teach those with vision loss, to help them thrive. And of course, what that means to thrive will look differently depending on the person. We have a virtual reality room that we use to give local medical professionals and those studying to become medical professionals a small glimpse into some of the challenges their patients may be facing, doing everyday things like here I'm showing our room with folks trying to cross the street without having much vision. We also relaunched our website to make it seamless for folks to learn what they want to learn. Daily living tasks like cooking or medication management, social, emotional support associated with adjusting to vision loss, recreational topics like gardening or adapting card or board games, Braille, of course, our founding topic, working how to adapt Outlook, for instance, to better meet your vision needs. And technology, because there's one thing to say, we have all sorts of modern tech tools that could help those with vision loss today, but quite another to know how to use them to best effect. And each workshop we offer at Hadley is short, focused, and filled with practical tips that you can put right into practice. For instance, putting one bump dot on the top of a blood pressure med you take once a day, and two on the top of arthritis meds you might take twice a day. Our tech tutorials break things down into simple step-by-step instructions and can be listened as often as someone wants to. One of the comments I love to read it sounds something like this. It felt like Doug was sitting right down next to me. He didn't rush or assume I knew all those tech terms. I just felt good listening to him and learning with him. Importantly, each workshop at Hadley is staffed by vision professionals. So while much of what we have is online, no question should go unanswered, and Hadley's individualized help is just an email or a call away. We also host a monthly discussion groups on 10 different topics. These call-in groups range from gardening to crafting to our most popular one, technology. It's really important to us at Hadley that all of our learners have the opportunity to ask their own questions, hear from our own experts, and importantly, learn and hear from each other. What we found is these groups are invaluable for many. It replaces a sense of isolation and loneliness some feel if they've acquired vision loss later in life, to a community of others who really get it. And while we love our new online platform, we realize that not everyone feels comfortable online. And in fact, you might be learning how to better use your computer now that your vision is faded, and may be difficult to learn on your computer. So Hadley also sends out large print, braille, and audio tracks to folks all over the world. And last but not least, Hadley's free. There are no doctor's notes needed, no waiting lists, no trips to our office required, and absolutely no bills to pay. Really, with just one simple sign up, all of Hadley is there at your fingertips. So I invite you to check out Hadley's Help for yourself. You'll find us at hadley.edu. And at this point, I'd like to introduce the next speaker. So it's my honor to introduce Dr. Jill Lykon. Dr. Lykon is the clinical hematology oncology pharmacy coordinator at the University of Miami Hospital and Clinics. She received her Doctor of Pharmacy from Temple University in Philadelphia, and her daily work involves developing treatment plans for oncology patients, managing chemotherapy, immunotherapy toxicities, and working with patients and their families around expectations of cancer treatments. So with that, I'll leave it over to Dr. Lykon.
Thank you, Joan, so much for the introduction. So again, today I wanted to talk about some of the cancer treatments that we have for breast cancer. As you guys know, globally, breast cancer is the most frequently diagnosed cancer for women and the leading cause of death for cancer-related death for women in the United States. Breast cancer can be treated, though, in several different ways. Really, the treatment for breast cancer does depend on the cancer itself, as well as how far it's spread. People with breast cancer often get more than one kind of treatment. We call this, often in the oncology world, a multimodal approach. Often, surgery, chemotherapy, and radiation is the backbone of treatment. Chemo that you typically think about, which is very toxic and can lower blood counts and require platelet and red blood cell transfusions, is not the same as it used to be. Recently, we have had newer advancements in our chemotherapy products, and I'm kind of going to talk about that a bit today, and how these new advancements are able to treat different types of breast cancer. Like advancements we have seen in our iPhones over the past couple of years, if we think back to the first iPhone and the iPhones that are out today, we've also seen the same type of advancements in chemotherapy. Historically, chemotherapy has always been non-specific and targets rapidly dividing cells. These chemotherapy medications can work on our normal cells, such as our hair follicles or our gut mucosal lining, or chemotherapy can target what they're supposed to be targeting, and that's the cancer cells. Recently, advancements have been in chemotherapy has created those drugs that we give to target the breast cancer cells more specifically. Today, we have smarter chemotherapy. We also have genetic testing that's also an integral part into the breast cancer management. Although most breast cancers are sporadic, meaning they occur randomly, There is a mutation called a BRCA mutation, which today we have drugs such as olaparib or talazoparib that can target this mutation. I do want to stress, though, that unfortunately the BRCA mutation only accounts for a small percent of breast cancers, and so these drugs do not apply to everyone. The National Comprehensive Cancer Center Network, also known as the NCCN, and the American College of Medical Genetics and Genomics have extensive guidelines which reviews the criteria for women to be considered for germline mutation testing. Additionally, tumor cells, aside from our genetics, can tell us a lot about the type of cancer that a patient has. We can categorize the cancer cells into specific subtypes, and we have specific chemotherapies that can target those subtypes. One of the most notable subtypes of breast cancer therapy is those patients that have HER2 positive breast cancer. We also look at estrogen or progesterone positive breast cancer. In the absence of either one of those receptor positivities, we have triple negative breast cancer. To begin our discussion of the advancements of chemotherapy, those patients presenting with HER2 positive breast cancer, which usually is an overproduction of a specific protein on the outside of the breast cancer cells. We've developed monoclonal antibodies, which are specific proteins in the form of chemotherapy that target these tumor cells on the breast cancer cells. Recent advancements in chemotherapy have exploded our arsenal to target HER2. Initially, when HER2 was developed and drugs were used to target this receptor, there was only one drug available on market for that. Now we have up to 5 drugs that target HER2. For breast cancer tumors that do not express HER2 and they express estrogen positive or progesterone positive breast cancer, we can use estrogen decreasing therapy. Typically, this therapy can go on for 5 to 10 years. What's important is that these medications can have side effects. Any medication that has a side effect or any medication that's prescribed by a breast cancer doctor should always be, the patient should always discuss with the provider or their healthcare team any side effects that they're having and should not abruptly discontinue the medication without talking to the provider. For patients in the metastatic setting, we have newer drugs that target CDK4 and 6. These drugs, such as abemaciclib, palbociclib, and ribociclib, can be used in combination with estrogen decreasing therapy, such as fulvestrant. This combination has recently showed improvement in overall survival for breast cancer patients compared to those taking estrogen decreasing medications alone. So again, we're doing a lot of clinical trials in order to advance breast cancer therapy. In patients neither expressing estrogen receptor or progesterone receptor or HER2, these we consider triple negative breast cancer and traditionally are treated with standard chemotherapy. What's great though, in the last year, we actually had a newer monoclonal antibody that was been approved to treat triple negative breast cancer. Again, advancing therapy in one of our harder subtypes of breast cancer to treat, which is really great for all of our patients. And so lastly, as a pharmacist working in this unique cancer patient population, I want to stress and talk about some supportive care, because I wouldn't be a pharmacist if I didn't address the supportive care needs of our patients who are getting breast cancer treatment. And so if I took a poll right now of the room, I would bet most of you associate chemotherapy with nausea and vomiting. And so nowadays we have newer drugs that treat nausea and vomiting or prevent nausea and vomiting. Some of those include palonosetron or fosaprepitant, 2 drugs that are very strong and help with decreasing the amount of nausea in patients. I always tell my patients when I'm rounding down them, if you're vomiting or you're nauseous, that means I'm not doing my job right, because I know that there are medications out there that can help prevent any nausea and vomiting. The advancements that we have made in chemotherapy are mostly due to clinical trials. As a pharmacist that works in an NCI designated cancer center, I have seen firsthand how clinical trials have advanced our treatment for breast cancer and have led to better outcomes for our patients. Enrolling in clinical trials should always be done at at a cancer center that has appropriate clinical trials. You should not be going off and doing them on your own, as they can be dangerous. Clinical trials here at UM have increased our patient populations, especially in the breast cancer realm, and have brought more patients to our center who are looking for these clinical trials. I would like to thank Accessible Pharmacy Services for the Blind for inviting me here today to talk to all of you. I would like to thank my patients and their family members, my teams of doctors and nurses, and all the support staff who help make the goal of curing cancer possible.